Under the Constitution, Congress has the power to tax and to spend. And within those powers are Congress's responsibility to tax and spend wisely and make decisions on how best to prioritize finite federal resources among all the programs and policies implemented across the United States and the world. It is also Congress's responsibility to conduct oversight of how federal funds are spent and to hold agencies accountable for their spending and their prioritization of programs and policies. This hearing will focus on the President's fiscal year 2024 budget request for the Indian Health Service and how best to allocate funds to the IHS and consider what changes need to be made. IHS, like every other agency, is accountable to the American people, and particularly to the tribal communities and Native people that they serve. Through treaties and federal statutes, the federal government has assumed the responsibility of providing health care for American Indians and Alaska Natives, and IHS is the primary agency charged with that responsibility. IHS provides an array of medical services to Native people, including primary care, emergency services, public health nursing, and substance abuse care, just to name a few. As previous hearings have shown, IHS has not always delivered the best possible care, and improvements must be made. Over the past several years, Indian country has seen substantial federal funding increases across agencies and programs that serve Native communities, including for tribal health care and health facilities. The federal government has also increased its spending generally over the past decade, and that means a higher deficit and intense concern for many Americans about the fiscal future facing our nation. In fact, I just did a poll this week as to some of the issues that are the most important to my constituents in the state of Wyoming, and the budget and government and federal spending is at the top of the list. The President's budget proposes a $2.45 billion increase for IHS in the next fiscal year. The budget also proposes to shift contract support costs and Section 105L lease funding to mandatory spending in fiscal year 2024, and then further shift all IHS funding to mandatory spending beginning in fiscal year 2025. While I understand the need for consistent funding, I also believe that continued oversight and accountability of IHS is needed at this time. We need to see significant progress before how IHS is funded can significantly change. The discretionary appropriations process helps to encourage and facilitate oversight, as well as further discussion about what innovative approaches IHS should incorporate to ensure the health care provided to Native communities is not only of high caliber, but fiscally responsible. It is also important to note that IHS remains on the Government Accountability Office's high-risk list as one of the government programs and operations vulnerable to waste, fraud, and abuse. And while the agency has made some progress on key recommendations, much more work remains. Specifically, this subcommittee has heard many concerns about the Purchased Referred Care Program, including how claims are either accepted or denied, as well as how slowly these claims have been paid by IHS, which is then affecting the personal credit scores when the claims are sent to collections. Ensuring effective care when IHS facilities cannot provide such services to tribal members is critically important and has life-changing implications. In short, equitable access to PRC funds must be a priority. There are also problems with the speed of completing the 1993 priority list for Indian health facilities. It's now 30 years later, and the list has not yet been completed. That is unacceptable, and our tribal members have suffered as a result. There are questions on how to best care for individuals suffering from substance abuse and mental health disorders, how to ensure full hiring and retention of IHS medical and support personnel, and how to expand access to labor and delivery services for women in their home communities, and how to provide dental services. IHS medical staff and tribal health professionals are the boots on the ground ensuring health care to Native peoples, and it is the best that it can be. Their work is needed now more than ever. Continuing oversight of IHS to ensure they are fulfilling their mission of efficiently and effectively for the benefit of Native communities is a main priority of this subcommittee, and it will help to make sure resources get to where they need to go. Today, that means having a good discussion about the agency's budget and where resources should be allocated. I want to thank the director for being here to testify today, and I look forward to your testimony. We held a hearing in March on issues, speaking with tribal members from around the country as to ways to improve IHS services. And I am sorry to say that the director did not come to that hearing. I thought that the testimony was extremely enlightening and helpful, and I wish that you had been here to listen to the women who traveled across the country to provide us with that information. This committee has heard from tribes and tribal organizations about the importance of purchased referred care funds for specialty care, and these PRC funds are especially critical in areas without large IHS hospitals where costs can be internalized. We have learned from tribes and federally managed service units that there are multiple obstacles to their tribal members receiving referrals for specialty care. And this is one of the reasons identified by the GAO for IHS being on its high-risk list. What steps has IHS taken to address the deficiencies identified in the GAO report?
Thank you for that question. And I also want to note that I support the comments that you make in terms of holding Indian Health Service accountable. To that, there are a number of steps that I have taken already. One is a report that I have already noted that we have posted on the Indian Health Service website that describes the priorities that we're focusing on, including how we improve purchase and referred care for all of the patients that we serve. There are other ways that we have done that. We have acknowledged fully not just the GAO report, but the OIG, the White House report, and also internal reports that we have set out. And all of those recommendations that we receive from those reports are similar in nature, and those are also published on our IHS website. One, to first acknowledge what those recommendations are, and two, to ensure that they are incorporated into the work that we are doing today.
Our committee has also heard from tribes and tribal leaders that they have been referred to collection agencies because IHS does not timely pay the bills from the PRC providers. Is this supposed to happen in the first place, number one? And number two, what are you doing to address that?
Thank you. No, this should not happen at any place for the services that we provide. Unfortunately, at this point, we are looking at our system to streamline our PRC process to ensure that patients do not fall into this particular situation. There are a number of steps, and it is a complicated process, but there's still too many steps in our process, and we are working to reduce those so we do not have people that fall into this particular situation.
And when this happens, because we know that it does, and you've acknowledged that, what other procedures or mechanisms does IHS have in place to make sure that these issues are clarified with the credit reporting agencies so that IHS's failure to pay doesn't result in negative credit consequences for individual Native patients?
Thank you, Madam Chair. One of the first things that I did at the Indian Health Service, because I was also the director at the Navajo area and saw this gap between the regional and the IHS headquarters, upon my appointment as a director, I immediately reduced that gap by bringing in area directors. We have 12 regions and 12 regional directors, bringing them to the table and ensuring our coordinated and efforts to try to improve not just PRC, but all of Indian Health Service, and having my leadership team at one meeting to make sure that we all understand our responsibilities. I now meet with my team on a quarterly basis. We're using the work plan to make sure that we're meeting the deliverables of that plan.
Recruitment and retention continue to be challenges for the Indian Health Service, particularly in rural areas. We've learned that one of the obstacles in recruitment is the IHS's personnel system. On average, how long does it take from job announcement to onboarding for IHS to hire health providers?
Too long.
What can be done to fix that?
So at this point, we're looking at an overall 28% vacancy rate. And even in the mental health space, which is a very important topic for me, we're at 40% vacancy rate at the Indian Health Service. What we have done, and a couple examples that we have done to rectify this situation is, of course, as part of the $3.5 billion water infrastructure bill, that we now have a agency-wide approach to this, meaning that we don't have 12 different areas trying to recruit. We're using one way to bring in people into the Indian Health Service, and therefore, again, being more efficient. The other thing that we're doing is we're standardizing and building out professional systems throughout our agency to really leverage the best practices that we have, again, to streamline and act as efficiently as possible. We have done that on the onboarding side, and we're now doing that on the hiring side.
Very quickly, because I'm out of time, have your changes or the efforts that you've made, are they having results?
Yes, ma'am.
Okay. In light of the fact that I think we've got some extra time here, and I think that there were perhaps some follow-up questions that folks wanted to ask, we're going to have another round of questioning. I don't think it will last very long. I just have a few questions I'd like to ask. I'd like to follow up on what Mr. Carl was talking about with regard to fentanyl. That's one of the issues. And Wyoming has been hit hard with that as well. And we have two tribes in Wyoming. We have the Northern Arapaho and the Eastern Shoshone. We have had over 14,000 pounds of fentanyl cross the border over the last 2 years. And it's obviously something that has affected our ability to provide health care to our tribes. We've got the addiction problems. And so I'm going to ask you, until we start stopping the flow of fentanyl, it is going to continue to be the scourge of our communities, whether it is on reservations or it is in Portland or Denver or wherever it may be. What has your agency done in terms of asking President Biden or Mr. Mayorkas to please help to control the border in order to stop the flow of illegal drugs coming across?
We have worked very closely with the Department of Interior on tribal lands. That they are the responsible party for law enforcement, working with them to coordinate a number of efforts to make sure that we're addressing and bring safe care to our Native reservations. That being said, we're working very closely with Secretary Haaland on her Road to Healing, which is, of course, is a boarding school initiative, and then now the MMIP, which is the Missing and Murdered Indigenous People. And moving from that, really helping support and being that health arm of even as late as yesterday, talking about how do we build out facilities in our Native communities where we can, where individuals that need to be incarcerated, and then how do we provide that health care if there's health care needed in that. So we're starting that conversation. We will continue that as we try to build out more resources for Native American lands.
Well, Ms. Tso, would you agree with me that stopping the flow of illegal drugs across the border is probably one of the most important things we can do to address the drug crisis and fentanyl crisis we have in this country?
Yes.
Okay. I'd also like to continue talking about some of the hiring issues associated with your agency. And the question I have is it possible for tribes with federally managed service units to contract or otherwise assume control of the hiring function to carry out those activities more efficiently for the IHS related to your job and employment situation?
Yes, at the Indian Health Service, any tribe that assumes their own healthcare program also does their own hiring of what was once operated as IHS programs. So about 60% of the Indian Health Service has been contracted. Tribe and tribal governments have responsibility for all the hiring in those areas. We do some recruiting for them because we believe that we have a little wider span to be able to get job information out there.
In terms of the funding for those positions, is that part of the $9.65 billion that you are requesting, or do those tribes pay for those services or those employees themselves?
Our entire budget includes tribes and urban programs.
Okay. Even when they do their own hiring?
Yes, ma'am.
Okay. For federally managed service units with very high vacancy rates, does IHS have the ability to deploy Commissioned Corps or other HHS health providers to those areas to address immediate needs?
Certainly during the COVID-19, and particularly when I was in Navajo, we had a number of resources that came to us, including the Commission Corps. Unfortunately, over the past few years, there's been a decline in commissioned officers being brought on, and so we don't have always the luxury of having those. We have about 1,400 officers at the Indian Health Service right now that either work for IHS or are assigned to tribal or urban programs.
And finally, at our previous hearing about IHS, one of the stories we heard was about a tribal member who studied to enter the medical profession with the intent of coming back to her community to work at the IHS facility there. But that was not an option for her when she was finally offered a job at IHS. Is there a specific policy in place to promote tribal members being able to serve in their own community as medical professionals?
We follow the Indian Preference Law, which of course are members of federally recognized tribes that have tribal enrollments, that certainly they have preference at the Indian Health Service. Now, we can't specifically say or guarantee someone a job that you can work at this particular location, but if there's a job open, that's certainly the place that they can apply to and be considered.